Hey guys, this is Mrs. Page, and this lecture we are going to cover liver disorders. First, we will cover cirrhosis. So cirrhosis is extensive, irreversible scarring of the liver, and inflammation is caused by toxins or a disease that results in the destruction of liver cells. The tissue becomes nodular, and it can block bile ducts and blood flow throughout the liver. Early in the disease, the liver will be enlarged and firm, and then later in the disease, the liver will shrink and become harder. There are different types of cirrhosis. There's post-necrotic cirrhosis, which is caused by viral hepatitis and certain drugs or other toxins. And hepatitis C is the most common cause of this type of cirrhosis and liver cancer in the United States. Alcoholic cirrhosis is caused by chronic alcoholism, and if alcohol is withheld, fatty infiltration and inflammation is often reversible. There's biliary cirrhosis, which is caused by chronic biliary obstruction or an autoimmune disease. And then there's also non-alcoholic fatty liver disease, which can also lead to cirrhosis. There are a lot of different complications that go along with cirrhosis. There is compensated cirrhosis, which is when the liver is scarred and cellular regulation is impaired, but it can still perform essential functions without causing any kind of major symptoms. There's decompensated cirrhosis, which is when liver function is impaired with obvious signs and symptoms of liver failure. Portal hypertension is when there is a persistent increase in the pressure within the portal vein. And the portal vein is the blood vessel that delivers blood to the liver from the stomach, intestines, spleen, and pancreas. This results from an increased resistance or obstruction of the flow of the blood through the portal vein and its branches. The blood is then going to seek collateral channels around that high pressure area, and the blood will flow back up into the spleen, which can cause splenomegaly. And then the veins in the esophagus, stomach, intestines, abdomen, and rectum will become dilated. Ascites is the collection of free fluid within the peritoneal cavity. This is caused by increased hydrostatic pressure from that portal hypertension. The liver is not able to produce albumin because of impaired liver cell functioning, and albumin is what keeps the plasma in the intravascular space. So that fluid is going to shift from the intravascular system to the abdomen, and this is called third spacing, and that's where you get your ascites. Esophageal varices, these are fragile, thin-walled esophageal veins that become distended and tortuous from increased pressure resulting from portal hypertension. The decreased prothrombin production, and because the liver is impaired, also puts the patient at a risk for bleeding. Bleeding esophageal varices are life-threatening medical emergencies, and you might see the bleeding as hematemesis, so they might throw up the blood, melena, which is passed in the stool, or a loss of consciousness. And any activity that increases abdominal pressure can increase the likelihood of the varice to bleed. Here is a picture of ascites that you will see. So this distended abdomen, it's because there's fluid in that peritoneal cavity. And then here is an endoscopic picture of a esophageal varice right here. So you can see that anything that's going to increase that pressure would be easy for this to pop. Splenomegaly is also a complication of cirrhosis. This is from the backup of the blood into the spleen. An enlarged spleen will destroy platelets, which causes thrombocytopenia and increases the risk for bleeding. And thrombocytopenia is often the first sign of liver dysfunction. Biliary obstruction is also a complication. Production of bile in the liver is decreased, and it can become obstructed, and it prevents the absorption of fat-soluble vitamins, specifically vitamin K, which means that those clotting factors are not going to be made in sufficient quantities, putting the patient at a risk for bleeding and bruising. Jaundice, which is the yellowish discoloration of the skin, Liver cells cannot effectively excrete bilirubin, which results in excessive circulating bilirubin. Edema, fibrosis, or scarring of the hepatic bile channels and the bile duct can also interfere with normal bile and bilirubin excretion. So, buildup of that bilirubin causes the jaundice, and pruritus or itching skin is common with jaundice as well. Hepatic encephalopathy. The exact mechanisms that cause hepatic encephalopathy are not really understood, but it is known that high ammonia levels are common in patients with hepatic encephalopathy. Early signs are going to be sleep disturbances, mood disturbances, mental status change, and speech problems. Later symptoms will be altered level of consciousness, impaired thinking processes, and neuromuscular problems. There are 4 stages of hepatic encephalopathy. On page 1157, table 53.1, I would recommend giving a quick look at that, which lists out the 4 stages of hepatic encephalopathy. Here is a picture of jaundice. You can see it on the legs and also in the face. And you can also notice that the sclera of the eyes are also yellow. Hepatorenal syndrome is a sudden decrease in urinary flow. It also includes elevated BUN and creatinine levels and increased urine osmolality. This indicates a poor prognosis regarding cirrhosis. Spontaneous bacterial peritonitis, or SBP. It usually results from bacteria in the bowel reaching the fluid that's causing the ascites. You might see fever, chills, pain, and tenderness, and that ascites fluid needs to be drained and obtained for culture, and then IV antibiotics will be used to treat that. And there's also the hepatopulmonary syndrome, which is from that excessive acidic fluid that is causing an increase in the intra-abdominal pressure, which limits thoracic expansion. So they have trouble taking big, deep breaths. Assessment of cirrhosis, you want to start with a history. Get their age, gender, employment history. Specifically if they're a healthcare worker, firefighter, or police officer, because these patients are at risk for hepatitis, which can lead to cirrhosis. Ask them about their exposure to alcohol, drugs, herbal preparations, or chemical toxins, which can lead to hepatitis and cirrhosis. Ask about needle stick injuries and sexual history and orientation. Homosexual men are going to be at a higher risk for hepatitis A, B, and C, which is a risk factor for the development of cirrhosis. Signs and symptoms. Early signs and symptoms, you'll see fatigue, significant change in weight, GI symptoms such as anorexia and vomiting, pain in the abdominal area, liver tenderness, and hepatomegaly. Late signs, you'll see GI bleeding, jaundice, ascites, and spontaneous bruising. Then you'll want to do a physical assessment on a patient with cirrhosis. You'll start with an abdominal assessment, check for ascites. Orthopnea and dyspnea will also be present with ascites because of the interference from lung expansion, because of all that extra fluid. Caput medusae, which is dilated abdominal veins, you might see those. And you also want to measure abdominal girth. Other physical assessment that you would want to check: blood in the stool or vomit, fetor hepaticus, which is fruity or musty odor of the breath, amenorrhea, testicular atrophy, gynecomastia, and impotence in men from the inactive hormones, neurologic dysfunction, and there's also asterixis, which is the rapid, non-rhythmic extension and flexion of the wrist and fingers. So it kind of looks like hand flapping. You'll also want to do a psychosocial assessment on them. They can have changes in level of consciousness and orientation. So you might see agitation, euphoria, depression, sleep pattern disturbances, emotional, physical, and financial changes from repeat hospitalizations, and they might be going through alcohol withdrawal if the patient is alcohol dependent and they have alcoholic cirrhosis. On the left-hand side, this is a picture of caput medusae. So these veins are engorged, dilated. It kind of looks like Medusa's hair. That's kind of where they got the name from. And then on the right-hand side, this is asterixis, that hand flapping that you can see. So their wrist will move back up and down, back and forth. Laboratory assessment for cirrhosis. AST, ALT, and LDH are typically going to be elevated because they are released into the blood during inflammation. Bilirubin levels will be increased because they're not being excreted by the liver. Albumin levels are decreased because the liver is not able to produce albumin. PT and INR is prolonged because the liver is not producing prothrombin. Platelet count is low because of splenomegaly, and the spleen is destroying platelets. Anemia from the blood loss and ammonia levels can also be elevated. Diagnostic test: X-rays of the abdomen to show hepatomegaly, splenomegaly, and ascites. CT, MRI. Ultrasound of the liver is usually the first assessment if liver disease is suspected. There is an ultrasound transient elastography, which measures liver stiffness, which helps determine the amount of liver disease that's present. Biopsies can be taken, but the patient is at risk for bleeding if they have cirrhosis, so you have to be careful when you're taking biopsies. Arteriography can detect portal vein thrombosis, an EGD to visualize esophageal varices, and an ERCP to visualize the biliary tract to see if biliary obstruction is causing that cirrhosis. Interventions for cirrhosis, specifically managing ascites. Nutrition therapy, they should be on a low sodium diet to control the fluid. And for late stages, they might be getting IV vitamin supplements such as thiamine, folate, or a multivitamin. Drug therapy, they'll be on diuretics to reduce that fluid accumulation. They'll have a paracentesis, which is when a catheter is inserted into the peritoneal cavity to drain that fluid. You want to make sure that the patient voids prior to the procedure because you don't want the person that's conducting the procedure to accidentally puncture the bladder. The head of the bed should be elevated. Monitor vital signs, document characteristics of the fluid, and then assess for leakage of the dressing. Respiratory support, if they have the hepatopulmonary syndrome. So monitor oxygen saturation, keep the head of the bed elevated, and weigh daily. Preventing or managing hemorrhage, preventing bleeding. Esophageal varices are the most common cause of upper GI bleed in patients with cirrhosis. You want to screen for varices before an endoscopy. A beta blocker can be used to prevent bleeding, and antibiotics can be used to prevent infection, which can lead to bleeding. Managing an active bleed, they can have vasoactive drugs such as octreotide acetate and vasopressin to cause vasoconstriction and control the bleeding. Endoscopic variceal ligation, which is the application of small bands around the base of the varices to decrease the blood supply, and then eventually they will die and fall off. Sclerotherapy, which is when the varices are injected with sclerosing agents, kind of like how they treat spider veins. A balloon tamponade with esophageal stents can be done. Transjugular intrahepatic portal systemic shunt. This is when a needle is guided through the liver into the portal vein. A balloon enlarges the tract and the stent keeps it open. So with cirrhosis, normal blood flow through the liver is blocked by scarred tissue. This shunt connects the liver to the hepatic vein, and it bypasses all this extra pressure on the portal vein, which reduces the risk of bleeding and lowers the pressure of an active bleed. NG tube can be inserted to detect new bleeds, packed red blood cells, fresh frozen plasma, albumin, and platelets can be given through a large bore IV. You'll want to monitor vital signs, coagulation studies, platelets, and INR. Preventing or managing confusion. You want to assess the neurologic status and monitor the neurostatus during treatment. Dietary limitations. Normally, a patient with cirrhosis will be on a high carb, moderate fat, high protein diet, but if they have a high ammonia level, they want to be on a moderate protein, not a high protein diet, moderate protein and fat, and simple carbs, because protein breakdown causes an increase in ammonia production. So we want to limit that protein to avoid from increasing the ammonia level. Drug therapy, lactulose will be used, which promotes the excretion of ammonia in the stool. They can also be given antibiotics if the lactulose doesn't help, because it can act as intestinal antiseptics, and destroying the normal flora in the bowel will diminish protein breakdown, which will decrease that ammonia production. Managing pruritus, which is the itching and dry skin, which is a result of jaundice from the increased levels of bilirubin. Usually this gets worse in warmer conditions and in the early evening and at night. Help the patient avoid being too warm, keep their skin moisturized, and avoid irritants that can be applied to the skin. Cold compresses and steroid creams can help, and if it is so bad that the cool compresses and steroid creams aren't helping, they can be put on SSRIs to help with the pruritus. Home care for cirrhosis. Physical adaptations should be provided for the home, so the bathroom should be close because of diuretic and lactulose treatment. They might need a bedside commode, they might need adult pads or briefs, and the bed might need to be one that can be elevated to help alleviate respiratory distress. Ascites management. If the patient has a drain for ascites, make sure to tell them not to drain more than 2,000 mL off at a time to prevent hypovolemic shock. Nutrition. Small frequent meals are best tolerated. Again, depending on whether or not they have high ammonia levels will determine what kind of meals that they are eating. Drug therapy and side effects. You want to teach them about the side effects of diuretics, or if they're on H2 receptor antagonists. They should avoid NSAIDs, herbs, vitamins, and minerals without an okay from the doctor. And signs and symptoms to watch for. You want to teach the family members signs of hepatic encephalopathy, because that would indicate that the patient is getting worse. So they need to be brought in. Nursing diagnoses for cirrhosis. They have a potential to have any of these. Fluid overload due to third spacing of the abdominal and peripheral fluid, or ascites. Potential for hemorrhage due to portal hypertension and subsequent GI varices. Acute confusion and other cognitive changes due to increased serum ammonia levels and or alcohol withdrawal. And pruritus, or impaired skin integrity, due to increased serum bilirubin and jaundice. Next, we will move on to hepatitis. This is widespread inflammation and infection of liver cells. There's viral hepatitis, which can be acute or chronic, and then this is the most common type. You can have hepatitis A, B, C, D, or E. Other types of hepatitis can be caused by infections such as the Epstein-Barr virus, herpes simplex, varicella zoster, or cytomegalovirus. Chemicals, drugs, and some herbs can also cause hepatitis, but we're going to be focusing on viral hepatitis because it's the most common. Hepatitis cases must be reported to the health department, which then will notify the CDC. Hepatitis A, or HAV, is caused by an RNA virus of the enterovirus family, It survives on human hands. It's resistant to detergent and acids, but it is destroyed by bleach in extremely high temperatures. This is common in countries where sanitation is poor. It's spread by the fecal-oral route or consuming contaminated food or water. Sources can be from shellfish that is caught in contaminated water and food contaminated by food handlers that are infected with hepatitis A. Signs and symptoms are mild. It can be a mild flu-like infection. It might mimic that. And prevention will be hand washing, avoiding contaminated food or water, receiving the HAV vaccine before traveling to areas where the disease is common, like Mexico or the Caribbean, receiving the vaccine if living or working in enclosed areas like the dorms, prisons, daycare centers, and long-term care facilities. Hepatitis B is caused by an antigen that circulates through the blood. It's spread by unprotected sexual intercourse with an infected partner, sharing needles, syringes, or other drug injection equipment, sharing razors or toothbrushes with an infected individual. Accidental needle sticks or injuries from sharps will primarily be shown in healthcare workers. Blood transfusions, hemodialysis, direct contact with blood or the open sore of an infected individual, or it can also be transmitted by birth. Many people do not have symptoms and clear the virus from the body and develop immunity. Some do not develop immunity and they become carriers and they can infect others without being sick. The decrease in hepatitis A and hepatitis B is primarily from the use of vaccinations. The hepatitis B vaccine is recommended for people who have sex with more than one partner, men having unprotected sex with men, people with chronic liver disease, healthcare workers, firefighters and police officers, prisoners, or patients that need immunosuppressant drugs. Hepatitis C is the leading cause of end-stage liver disease. It is spread by blood, illicit IV drug needle sharing, blood products or organ transplants that are received before 1992, needle stick injury with contaminated blood that has hepatitis C, hemodialysis, healthcare workers, prisoners, or sharing of drug paraphernalia. It's not transmitted by casual contact, but they should not share razors, toothbrushes, or piercings with other people. Many people are unaware that they have been infected. And people with hepatitis C will not clear the virus, and then a chronic infection will develop. Chronic inflammation in the liver will eventually cause the liver cells to scar, which leads to chronic cirrhosis and puts the patient at risk for liver cancer. This is the most common chronic bloodborne infection in the U.S., and no vaccine is available. Hepatitis D, it occurs with hepatitis B, and it is spread via parenteral routes, so IV needles. Hepatitis E is a waterborne infection common after heavy rains and flooding. It can be caused by fecal contamination of food and water, and the clinical course resembles hepatitis A. Here is a visual of the different types of hepatitis. It explains kind of how it is spread and any kind of treatment for it. You guys can pause this and look at it if you want. Complications of hepatitis. There is fulminant hepatitis, which is sudden liver failure. Chronic hepatitis, which is inflammation that occurs longer than 6 months. Cirrhosis and liver cancer. Assessment of hepatitis. You'll start with a history. Ask them about if they have a known exposure to hepatitis, and ask them about risk factors. Physical assessment, signs and symptoms. You will see abdominal pain, yellowish sclera, arthralgia or myalgia, diarrhea or constipation, light clay-colored stools, dark yellowish to brownish urine, jaundice, fever, fatigue or malaise, anorexia, nausea, vomiting, dry skin, or pruritus. You want to conduct an abdominal assessment, so lightly palpate the right upper abdominal quadrant to assess for any kind of liver tenderness. Psychosocial assessment, they will show general malaise, inactivity, and fatigue that can contribute to depression. They might be embarrassed from the social stigma related to hepatitis. Family members might distance themselves from the patient because they're afraid they will get the virus. And anxiety and a financial burden will be present if they aren't able to work if they're acutely ill. Laboratory and diagnostic tests for hepatitis. You might see acute elevations in the liver enzymes, ALT and AST, in hepatitis A, B, and C. Serum total bilirubin levels will be elevated. There are different blood tests that they will do for people based on what hepatitis type that they think they have. So there's a different test for hepatitis A compared to hepatitis B, C, D, and E. Diagnostic tests, they will do a liver biopsy that confirms a diagnosis of hepatitis. It can also stage the liver damage or determine if there is liver cancer. And they might also get an ultrasound. Interventions for hepatitis, you want to promote nutrition. So they should have a diet high in carbs and calories with moderate amounts of fat and protein. Small, frequent meals are encouraged. You want to ask the patient about appealing food preferences because favorite foods are going to be tolerated better than randomly selected foods. They should have high-calorie snacks, and they might need supplemental vitamins. Managing fatigue. These patients should be on rest to reduce the liver's metabolic demands and increase blood supply to the liver. Rest periods should be integrated with alternating periods of activity. Drugs are used sparingly to allow the liver to rest, but they can be given in acute and serious cases. For hepatitis B, there's an interferon, alpha preparations, or nucleoside analogs. Hepatitis C, you can use direct-acting antiviral drugs or protease inhibitors. These can make patients susceptible to infection, so they should avoid crowds and people with illnesses. Complementary and integrative therapies will help promote general well-being and quality of life. There's milk thistle plant green tea or vitamin E that some people might use. Home care, they should be educated on preventing the spread of infection, so especially hand washing and sanitary disposal of feces. 2 different nursing diagnoses you might see for hepatitis is weight loss due to complications associated with inflammation of the liver, and fatigue due to infection and decreased metabolic energy production. Here is a little visual for you guys comparing hepatitis and cirrhosis. They are both liver disorders, and a lot of things will overlap, such as abnormal liver functioning, might lead to the need for a liver transplant, can lead to liver failure and liver cancer. But hepatitis is inflammation of the liver, whereas cirrhosis is scarring of the liver. Lastly, we'll talk about liver transplant. Patients with end-stage liver disease or acute liver failure that have not responded to the conventional medical or surgical interventions are a potential candidate for liver transplant. Cirrhosis is going to be the most common reason for a liver transplant. Other reasons might be chronic HBV, HCV, bile duct disease, autoimmune liver disease, alcoholic liver disease, and fatty liver disease. They are not considered for transplant if they have cardiovascular instability, severe respiratory disease, metastatic tumors, or if they are non-compliant. Liver donors. So we can have living donors and then not living donors. Candidates with the highest level of acuity will receive the highest priority and be on the top of the list for liver transplant. Donor livers are obtained primarily through trauma victims who have not had liver damage. The donor liver is transported to the surgery center in a solution that preserves the organ for up to 8 hours. Living donors can also be used. Usually it's going to be a close family member or spouse. The donor's liver is resected and implanted into the recipient, and then the liver will regenerate and grow in size to meet the demand of the body for both the donor and the recipient. Complications with liver transplant: there's acute graft rejection, so the body is rejecting this new transplant. Signs and symptoms will include tachycardia, fever, pain in the right upper quadrant or flank, and jaundice. This is treated with immunosuppressant drugs, such as cyclosporine, and these patients will be at a high risk for infection. Infection is another complication. It will commonly include pneumonia, wound infections, urinary tract infections, or opportunistic infections. Vaccinations are important, such as HIV, HBV vaccine. And prophylactic antibiotics, specifically broad spectrum, will help control this infection. And then also bleeding is another complication. That's all I have for liver disorders. If you guys have any questions, please feel free to reach out to me. Shoot me an email, bring a question to the Q&A session.